Thank you, Malay sir, for including me in this instruction course. And with all those present, I welcome you all. So, the topic given to me was retinal conditions with vasculitis, edema, and neovascularization with a clinical walkthrough. So, uh, we know that retinal vasculitis is the inflammation of the vessel wall. It is a clinical diagnosis which is associated with inflammation or ischemia of the retina. However, we cannot take a tissue biopsy from the retina for obvious reasons, and we need to have a systemic vasculitis to get a biopsy and confirm the diagnosis. It may happen in association with the retinal vasculitis can happen, not always as a rule, with systemic vasculitis. It may occur as secondary to infectious or a non-infectious intraocular inflammation, what Malay sir was talking. When it is associated with infectious etiology, there are associated changes in the retina, which include but are not limited to retinal vasculitis, retinal whitening or chorioretinitis, as we will see. The clinical classification that we get is the retinal vasculitis associated with primary systemic vasculitis, in which we have two conditions: one retinal vasculitis with variable sized vessels and one retinal vasculitis with exclusive small sized vessels. In variable sized vessels, we have Behçet's disease and SLE, and in the exclusive small sized vasculitis, we have conditions like Wegener's granulomatosis and Churg-Strauss syndrome. Then comes the second, retinal vasculitis associated with infectious, non-infectious diseases like tuberculosis, syphilis, organ-limited vasculitis like birdshot chorioretinitis, Eales disease, idiopathic retinal vasculitis, aneurysms and neuroretinitis, that is IRWAN, and the last is retinal vasculitis from a putative identifiable trigger like drug-induced, vaccination-associated, what we saw post-COVID, and tattoo-related vasculitis we are aware of. These all images are taken from internet. The retinal vasculitis associated with primary systemic vasculitis with variable size vessels, we have two conditions: Behçet's disease and along with Behçet's disease, SLE. So we get the classical oral ulcers, we get the classical mobile hypopyon, which could be bilateral, and then we have occlusive vasculitis. So Behçet's disease affects the Middle Eastern, Mediterranean and Asian descent people. It is an occlusive vasculopathy, that is, the vessel actually gets blocked. The medium sized vessels get blocked. Manifestations, we all are aware that oral and genital ulcers are there, erythema nodosum we see, pericarditis, meningoencephalitis. Ocular involvement may have anterior uveitis with a shifting hypopyon, the classic description, papilledema and occlusive vasculitis. Treatment is corticosteroids along with immunomodulatory and cytotoxic agents. Now there are adalimumab. I was just in the UVA symposium where they were talking a lot about this drug, and inflimixab, and have been shown to be effective. SLE is a secondary vasculitis of variable size vessels, classical butterfly rash, what has been described, optic neuritis and cotton wool spots. But most notably, these patients do not have anterior uveitis or any form of vitritis. The treatment combines immunosuppression with anticoagulation. In reports of retinal ischemia, the laser photocoagulation and intravitreal anti-VEGFs have been shown to improve the outcome. Again, the images have been taken from internet. Then small sized vessels we come to. This is a rare, but these are the ones where people die. Actually, death is known in these conditions. These are Wegener's granulomatosis and Churg-Strauss syndrome. The ophthalmic manifestations include conjunctivitis. I have a case report on Wegener's granulomatosis when I started my fellowship. So the patient had specific peripheral ulcerative keratitis, along with some amount of chorioretinitis with vasculitis. This is known in Wegener's. Chorgstros will have eosinophilic vasculitis along with SLE-like picture. Then we come to the conditions where infectious and non-infectious causes are there. And infectious etiologies can cause retinal vasculitis through direct or indirect mechanisms. Direct invasion of the vessel wall is known in Treponema pallidum, that is syphilis, rickettsia, Epstein-Barr virus, tuberculosis, and Bartonella. We are aware that vasculitis associated with infection of the retina and choroid occurs very commonly in syphilis, tuberculosis, and herpes family. This was something which because we see a lot of tubercular vasculitis, so I just thought dwelling into the detail of it. The collaborative ocular tuberculosis study evaluated 962 patients, of which only 59 patients had a PCR done. And of those who tested negative for PCR, 30% of those patients had systemic disease, including miliary tuberculosis, tubercular meningitis, and that showed the limited result, the limited kind of sensitivity of PCR test. At this time, the diagnosis of tubercular uveitis is primarily made by the clinicians based on the constellation of clinical and systemic symptoms. Organ-related vasculitis is limited to the retinal vasculature, managed by systemic interventions. Conditions like tuberculosis, herpes, syphilis, we require to treat specifically. Non-infectious conditions like sarcoidosis may also present with organ-limited retinal vasculitis. These are a few of my patients. Now we get the classical inflammatory vasculitis in these patients, and which has macular edema. We treated this patient with intravitreal Ozurdex. You can see at 1 month there is at the macula. Yeah. At 1 month we had this the resolution of the vasculitis element over there, and we have a macular star-like picture we developed. And in the next 3 months, this macular star-like picture disappeared, and so did the edema. So these patients responded well to intravitreal steroid. Eels disease is an obliterative vasculitis of unknown etiology. We all know the fundus findings, sheathing of the vasculature, and it affects more venules more than the arterioles. Capillary non-perfusion and neovascularization, vitreous hemorrhage is known, and so is TRD. The treatment for recurrent vitreous hemorrhage, the hallmark of Eels disease, is usually vitrectomy. However, intravitreal anti-VEGF has been tried. Corticosteroid injections intravitreally are given for macular edema. For drug-induced, vaccination-induced vasculitis and tattoo-induced, we have to be careful with drugs like methamphetamine, trimethoprim, and sulfamethoxam, what we call as Septran. Herpes C and interferon treatment. The treatment but naturally includes the removal of the inciting agents, intravitreal systemic corticosteroids, and immunosuppressive therapy. This is a very interesting phenomena where we document the patient came in October 23. The patient only had some amount of vitreous inflammation and an epiretinal membrane, a low-grade inflammation. So this was not a warranty for treatment. We tried to investigate the patient, and the patient was kept on oral ATT. Now the second picture is of the November 23. You can see that there is a very clear-cut vasculitis now developing in this patient, and epiretinal membrane becomes prominent, but there was no macular edema, so we didn't treat. And in January, the patient actually had a proper macular edema. So this is how macular edema in a tuberculosis evolves. It does not present initially the moment vitritis is there, the moment vascular occlusion is there. Macular edema may not appear. It appears at a different, and I believe you can see that the vessel block is nowhere close to macula. So the macular edema which is appearing as a result of the inflammation which is happening, not per se as what we get in CRVO or a BRVO. It is a aftermath. So that is why these patients respond very well to steroids. So this is another patient, and this was post anti-VEGF. This patient I chose anti-VEGF over steroid because of the hemorrhagic element, as simple as that. And the hemorrhage was kind of no, it was spreading right onto the macula. Investigations, the commonest investigations we do for these patients is complete blood counts with differential counts, then ESR along with quantiferin gold, VDRL. ACE is not routinely done, but I get CT chest done, and if it is looking like, then but naturally torch infection, and with the putative in identifiable trickle, the history is the catch point. I have seen one case of post-vaccination vasculitis with the Covishield. Treatment is oral steroids, rituximab, and for systemic diseases we have to treat the systemic disease, organ limited. We can add the corticosteroids, and for the putative identifiable trigger we have to withdraw the offending agent. The treatment of the neovascularization, PRP is done. Vitrectomy may be required for vitreous hemorrhage and tractional retinal detachment. But remember, before injecting, if there is any risk of tractional retinal detachment, then beware of the anti-VEGF agents. So this is one of my patients which developed a post-laser epiretinal membrane. So these patients kind of know these secondary epiretinal membranes, they do trouble. And this patient I am planning for a vitrectomy because the vision and the media is not as clear. So vitrectomy can be used to clear the residual vitreous debris following medical therapy to control intraocular infection. Thank you so much.
Dr. Manish, just one question. As far as tuberculosis is concerned, tuberculosis and retina involvement or uveitis, what is the minimum diagnostic criteria you use to start ATT?
Sir, if the patient has CT chest findings, if the patient, MAN2 is not the decisive factor definitely nowadays, the CT chest findings have to be there, because otherwise my pulmonologist usually writes there, I am starting this on the advice of the clinician, and these patients usually tend to roam around, and then they say, why are you starting when nobody else is starting? So I usually write for every patient which have the classical clinical findings of the inflammation, along with supportive evidence like CT chest, like quantiferin gold positivity. If these two are positive, then it is like behichak I can start these. But if there is no finding on CT chest, the CT chest is clear, then these patients usually roam around, and by and large, even if you advise, they will not take ATT. The pulmonologist will refuse the treatment.
I think very well said, Dr. Darius. What is your take? Because the thing is, I send the patient to physician, sir start कर दो. बोला क्यों कर दें जी? हाँ? तो मैंने कहा जी ये tubercular लग रहा है, इसलिए कर दो. So, what is your take? Or for that matter, Doc Saab is also sitting there. You can give your feedback on this point. Mic. Kindly give the mic here.
The key is that you send it to a physician who has some understanding of the kind of pathology, because if you just send to a random physician, that's the problem. So our place, in fact, inflammation looked after by Dr. Shishir. So he has somebody who we trust, who has knowledge of this. Otherwise, like Dr. Saab said, Dr. Tandon said, patient goes helter-skelter, and everybody has a different opinion that whether to start ATD, whether not to start. So I think having a tie-up with somebody who understands this, I think, and secondly, awareness from our side that this tuberculosis has these manifestations in the eye. Both these things help.
A short comment from your side, sir.
Yeah, I think I do corroborate with both the points. I also I do understand what Dr. Manish is saying, and he's absolutely right about it. But I think somebody who's more of an ocular pathologist and an ocular immunologist would be probably the right person to refer in these cases. So I think that way, I think having a combined this thing with them and then kind of referring with that. But yes, as far as Sir's question goes, I think as rightly said, I think at least from the physician's point of view, I think very pathognomic. Rather, even QTB gold is not something that they really take. QTB positivity to be really something which they need to start treatment for. I think it is more clinical based. So I think having a single referral person and that would be one of the better things to do. Rather, in my practice, what I have seen is that if you are following up for ocular diseases with a particular person, I think even drugs like methotrexate and all immunological treatments also fare much better with a single referral practice than this thing with a clear understanding where the patient is given a clear understanding of the this thing. And to a certain extent, I think even to date, TB treatment seems to be something which is a taboo in the country, and that I think that counseling is very important. So I think we need to probably move from just a CT chest, from a particular diagnostic test to probably more of counseling based and clinical feature based treatment starting.
Completely agree with your point that it is the moment you utter the word that you require anti-tubercular treatment, the patient roams around. The patient starts going that somebody will say this is wrong.
They want somebody to say no.
They want somebody, they actually search for people who want to say you don't require. And that is where you lose these patients and they come up with bigger complications.
So just a question, what should be the indication to do a vitreous tap? Like we haven't diagnosed it on the basis of any investigation.
Use the mic, Dr. Vijat.
And so all the investigations are normal, but I suspect clinically that this is a tubercular case. Should we do a vitreous tap to confirm?
One case, it is not diagnosed by me, but I can just share the experience with you. There was a colleague of mine who was treating a patient of intermediate uveitis which was not responding to steroids. In our city, we don't have any dermatologist. So default drug to go is steroid only. And if the patient, and this patient, most patients respond. This was not responding. So this patient went doctor searching and landed up with me. So I suggested him that you require a vitreous tap. This patient after 6 months again pops up to my clinic because I was the one who told that you get a vitreous tap done, and he kind of refused because nobody had asked. And the patient turned out to be B-cell lymphoma. So it was an intraocular lymphoma, and if it is not responding to the treatment that you are offering, then you will have to take. But no, it can never be the first go-to. Invasive procedure you don't have to do as a first go-to.
So after ruling out and seeing
After
everything,
ruling out, giving a treatment fair trial, because this patient could have very well landed up in my OPD and would have not responded to steroid in my hand either.
So let's say, if you just kind of turn his question around, what tap would you recommend, or what cultures would you recommend to a case of vasculitis which you have taken up for a vitrectomy, for any other cause? Let's say, for a vit-heme, or if you've taken up for a vitrectomy,
Like
do you corroborate your findings with the sampling, with a PCR sampling or something? Would you recommend that, or?
For my endophthalmitis cases, the one we get, we do a routine, the gram stain, the KOH stain, and culture sensitivity. Other than this, I have not had the fortune of treating any patient or diagnosing a patient. So I'm not qualified.
Actually, it is the conviction level of the treating doctor. So suppose if you are die-hard uvea guy, then probably you may end up doing a vitreous tap also. Otherwise, I think it's very difficult. Yeah.
But sir, actually the point is that the PCR, it picks up the dead organism. So in fact, just before coming here, I did a acute retinal necrosis, young lady referred from Kashmir. So immediately took the tap, and now we've sent that to Shankar Nethralaya for the PCR. So what my message is that even if it's not there in your city, that sample goes to SN. And SN, of course, it's not that expensive. It's okay. It's quite affordable because Shankar Nethralaya also does it as a service, and we get results quite fast. So I think message is that these things are available, and even I don't get it done in Delhi. When I'm sitting in Delhi, I still send a sample to Chennai. So these, if
That's
we are
a
looking
very
at,
useful
yeah,
information,
so if
yeah.
you want PCR, so VZV, HSV, CMV,
Who is the contact person for this? Where do we contact?
it's
JB.
yeah, Dr. JB and the lab. I'll give you the contact detail. It is very, very professional. You have to transfer the
Any
money electronically. I mean, the system is very
Any
smooth.
specific way of transferring the vitreous biopsy or something?
I think we don't even keep it cold. We just send it regular. It's a dead organism.
PCR is a dead organism, so you don't need to basically store it. There is, I think that DTDC and Blue Dart, they take the sample and send it. And within 72 hours, you'll get they have a chain of this thing. So they do initially they do a simple PCR and then they do kind of amplification of that. So then if you come with a provisional report, then they can kind of study it further.
Thank you. This is a